Hello, my name is Sarah Oakley. I'm an independent board certified lactation consultant, nurse and health visitor, and I specialise in tongue tie. I am the author of the book, Why Tongue Tie Matters. I'm going to talk today about complications that can arise from a tongue tie division and what to expect after your baby has had a tongue tie division. I get asked about complications quite a lot, and obviously when I'm seeing babies for division, this is something that I discuss with the parents before we go ahead. And the three most common complications that we see are recurrence of the tongue tie, bleeding, and infection. Infection is the thing that parents really worry about, and actually is the least likely thing to happen, really. It's very unusual to see an infection after a tongue tie division in any baby, but certainly in breastfed babies, because of the antibodies they receive via the breast milk and the fact that the milk generally goes direct from mummy to baby. There's no source of contamination risk there. It's very unlikely and would be very unusual for a breastfed baby to get an infection after a tongue tie division. But even where babies are fully formula fed and aren't getting the antibodies, provided the formula is made up correctly, the risk of infection after a division is extremely low. But it is important that the formula is prepared correctly with very hot water if it's the dry powder type, and that the bottles are sterile and everything. So cleanliness is very important for those babies. The most common thing that we see is recurrence of the tongue tie, and this is a thing that concerns a lot of parents, and parents often ask about recurrence and how likely is it, and will their baby suffer a recurrence. What we know from the research is that the tongue ties that seem most likely to recur are the thicker ones, and these tend to be the more posterior type tongue ties, so the tongue ties that are attached a little bit further along the underside of the tongue, closer to the base of the tongue. And they tend to be on the thicker side. And this is because they tend to contain more fascia. Tongue ties or lingual frenulums are a layered structure. They consist of an outer layer, which is mucous membrane, and then underneath that layer there can be a layer of fascia, and then there's the muscle at the base of the frenulum. And in some babies there can be more fascia than in others. Some frenulums, when we divide them, the outer layer is mucous membrane, and it is all mucous membrane, so they're just a very thin layer of mucous membrane. And those type of tongue ties do tend to heal quite well with minimal scarring. But if the frenulum is quite thick and contains quite a lot of the fascial layer, you're more likely to see some scarring, and that scarring is believed to be a factor in recurrence of the tongue tie, because obviously scar tissue isn't very elastic and isn't very stretchy, so it's more likely to cause a further restriction. We do occasionally see tongue ties where they actually seem to just heal back together again. So sometimes I've snipped a tongue tie and I've seen it a week later and it looks like it's just healed itself straight back together again, and that does happen. And obviously the mouth is a highly vascular area and does heal really well, so we're kind of fighting nature a little bit with this. And there will be those babies that heal very rapidly and where the tongue tie perhaps reattaches. There will also be those babies that, because of the anatomy of the frenulum, form more scar tissue, and in those situations that may then cause a further restriction in tongue function. Now, whether or not that impacts on feeding will depend on how much restriction that reattachment or that scarring is causing. In some cases, the effects of that will be quite minimal and the baby will continue to feed quite well. So I do see babies sometimes a few weeks after division where there is a bit of tension at the base of the tongue and there is a little bit of scar tissue, but actually the babies are feeding fine and we wouldn't intervene on those. But I also have babies coming back to me from time to time where they've had some further feeding issues, and when we assess them there is some tension there that needs redividing in order to rectify the feeding issues. We try where we can to avoid a redivision, because obviously if it's scarred up once and become tight, if we redivide, there's the real risk that it may just reoccur again. And recurrences after a second division seem to be anecdotally more common than after a first, but we don't have any studies on this, so it's very difficult to say with any certainty. But my own perspective is probably it's about 50-50 chance of improvement after a second division. I think we also have to ask ourselves, if there was no improvement after the first division, is it worth going for a second division, or are there other issues going on here? I'm more inclined to suggest a redivision in a situation where the mum experienced and the baby experienced a really good improvement in feeding after the first division, and then things have deteriorated as the wound has healed and as time has gone on. Recurrences we don't have actually any data on recurrences because we don't see every baby after division. In the ideal world, we would do the division and then probably review that baby every week for several weeks to see how the healing goes and to evaluate the outcomes. Unfortunately, on a practical level, that's not possible. Often parents have to travel for their division procedure, so travelling back multiple times for reviews is not necessarily practical. In an NHS or a public sector healthcare system, there may not be the resources and the time to do that. Most public sector healthcare systems are quite overstretched and they don't have the capacity to see people repeatedly, so they'll only see the ones that are having problems coming back to them. And in the private sector, there are similar issues. We're quite stretched as well. And obviously, if we're going to see babies and parents repeatedly for a period of time, there are cost implications attached to that. And obviously, we want to keep the cost of treatment down as low as possible to make it accessible for parents. The only data we have in relation to recurrence of tongue tie is on redivision rates. So we do have some data on how many babies end up having a second division. The ATP, the Association of Tongue Tie Practitioners in the UK, did a little bit of an audit a few years ago now, and we found that our practitioners were reporting anything from a 0 redivision rate up to a 10% redivision rate, but the average was around 3 to 4%. So on average, our practitioners were reporting that they were having to redivide in 3 to 4% of cases. Bobby Gahiri, who's an American ENT, published a study where he looked at, I think it was 700 babies, and he followed those babies up over a period of about 6 months, and he had a redivision rate of 3%. So this redivision rate of around about 3 to 4% seems like a reasonable figure to be suggesting to parents, but the fact is we don't actually know how many babies go on to have a redivision, because some of them will go to other practitioners. They won't come back to the original practitioner. So the original practitioner may be unaware that that baby had to have a repeat division. Some parents will not represent, obviously, at all. So in terms of recurrence rates, it's difficult to know how many are recurring, because some parents, if the problems return, may decide to switch to bottle feeding or may seek support elsewhere and may not come back to that practitioner. So it's actually quite a difficult thing to follow up on and to know. And obviously, sometimes people decide to give up the breastfeeding, and then maybe other things going on. It may not actually be a recurrence of the tongue tie at all. There may have been other reasons for that. So it is something where we need a lot more research and a lot more studies. Bleeding is the complication that frightens us all and scares us all. None of us want to see a baby bleed after a division, and normally the bleeding is incredibly light. It's often just a drop or two of blood. If the wound does bleed for a few minutes, it's usually a very light ooze, and it's usually very easily managed and controlled by giving the baby the breast or the bottle to feed on. And the pressure from feeding will very quickly bring it under control. So it's usually very minimal in terms of blood loss. But every now and again, you will get a baby that bleeds a little bit more, and that may be because that baby just doesn't clot as quickly as some other babies would. It may be that you've revealed an underlying clotting problem. That does happen occasionally. I've had that happen where the baby actually, when we transferred the baby into hospital, was found to have a clotting deficiency. It may be that the frenulum, because they can have this third layer in the base of them of genius glossus muscle, it may be that during the process of the division, the genius glossus muscle was caught by the scissors, or the practitioner caught a tiny little blood vessel that wasn't visible when they were dividing. And so there can be all sorts of reasons why a baby might bleed. But usually it's very easily managed. Obviously, in a community setting, we transfer into hospital to get assistance. In a hospital setting, what they do is use adrenaline to constrict the blood vessels. So you just apply adrenaline to the wound on a piece of gauze, and that constricts the vessels. Or you can use tranexamic acid as an alternative to that. And that works within a matter of minutes and is very successful. And about 1 in 7,000 babies will need adrenaline applied to the wound to help stop the bleeding. If that fails, you have to cauterize or stitch, and that's kind of your worst case scenario. And the data that we've managed to collect through the Association of Tongue Tie Practitioners shows that that's about 1 in 77,000 babies. So the chances of a significant bleed which require a surgical intervention are very, very remote, but obviously it is something that parents sometimes ask about, and obviously is something that concerns parents and practitioners alike, because it can be a concerning and stressful experience to see a baby bleeding. In terms of what to expect after a tongue tie division, that is highly variable. We often don't know how a baby is going to be after a division. The hope is that after a few days the feeding will start to settle down and improve, and that that will allow the parent to continue to breast or chest feed, or improve the bottle feeding if the bottle feeding is an issue. But obviously outcomes are not guaranteed, and outcomes are very variable from baby to baby. So some babies will instantly feed better. I have a lot of mums who instantly say the latch is much more comfortable, the baby seems to be swallowing more. I have a lot of mums of bottle fed babies who will say instantly the baby's not dribbling anymore, the baby's not gulping and choking on the flow anymore. And sometimes you'll see an instant improvement. Sometimes that instant improvement isn't sustained. So sometimes the initial feed after division goes well, but then by the next day, as the baby starts to work that muscle more and that muscle starts to feel tired and achy, the feeding may deteriorate again. So in the first week, I always tell parents to expect the feeding to be a little bit up and down and to have some good feeds and some bad feeds. And certainly in terms of efficiency issues, it can take 2 or 3 weeks for those babies to reach full efficiency, because they've got to build up that muscle, because the muscle in the tongue will not have fully developed in the womb due to the restriction. So the muscle is often quite weak to start with, and as the baby starts to work that muscle, it can feel quite tired and heavy and achy, which can impact on efficiency. So if you've got a baby that's been struggling with weight gain, been feeding constantly, don't expect those issues to resolve immediately. It may take 2 or 3 weeks for the baby's weight gain to pick up and for the efficiency and the feeding pattern to settle down and improve. So if you're doing things like topping up and expressing, you may need to continue to do that for some time. And I think it's absolutely crucial that parents access ongoing breastfeeding support after division, because often you have to revisit things like positioning and attachment. You may need to wean your baby off shields. You may need to continue to work on your milk supply and gradually and slowly wean off top-ups of express milk or top-ups of formula. So it can be quite a lot of work to do after division, and a division should never be regarded as an instant fix. So I hope that gives you some insight into what the complications around a division may be, and also what the outcomes may be afterwards, and what to expect afterwards, and to be realistic in those expectations.